Okay, so welcome to our last seminar of the New Frontiers seminar series. For those of you new to the WebEx platform, you only see 5 of us here, but there are over 70 of you attending. During the seminar, you can type questions in the Q&A, which is in the bottom right of your screen, and we will ask them when we get to the discussion section. So the format of this will be each presenter will give about a 15-minute presentation, and then we will open it up for questions. So lots of time for questions and conversation. So today is my great pleasure first to introduce my colleague, Dr. Caldera Moore, who organizes these seminars with me. Thank you. Louisiana Tech University President, Dr. Guice, who is here to help moderate and engage in a conversation about what we have learned from this pandemic and how we move forward. And then our 2 special guests to today's seminar, Dr. Lucio Miele and Dr. Rebekah Gee, both at the LSU Health Science Center in New Orleans. Dr. Miele was actually one of our very first seminar speaker in the New Frontiers series 8 years ago. And here he is back again. And he is the head of the Department of Genetics. He holds both an MD and a PhD researching in oncology and specifically breast cancer, and has been very active in the COVID response for Health Science Center in New Orleans during this time. And his colleague, Dr. Gee, is a OBGYN and I gotta look up all your titles, Rebekah, and part of the public health school there. She was also Secretary of Health for the state of Louisiana and has done a number of other things at the federal level and great things for the state and its healthcare over the last several years. So it's such an honor to have both of you here today. I told you I'd be brief so that you could get to what everybody is here for, which is to hear from both of you about what we've learned, where we've struggled, where we can be better, and where we go from here. So thank you both. And Lucio, you should be able to share your screen, and it's all yours. If you can find it now. I should have just let you leave it up. Don't forget to unmute.
Can you see this?
Yes, you're good, and I can hear you.
All right. Well, thank you so much. It's a real pleasure and an honor to be here and share our experience and what that could possibly teach us. So the world handed us a huge lemon about a year ago, and we had to learn how to make lemonade. And I'll tell you in a second what that entailed and what that could teach us for the future. So what we faced in the spring of last year, and I'm now speaking specifically of our campus, was a 6,000 people campus with significant exposure to both patients and the public, students, residents, and faculty visiting multiple healthcare facilities in Louisiana, and a lot of problems with the global supply chain. We very quickly, when we were tasked with setting up COVID testing on campus, faced problems with the supply of swabs, medium, PPE, test kits, plasticware, and equipment. Essentially, everything we needed had to be sourced from sometimes unlikely places, which is the first lesson. The supply chain for laboratory products and PPE is very fragile and not built to withstand a shock. What did we not have? Well, that's easy, very little. We did not have dedicated personnel for testing or budget or space. And we had slow and complex negotiations surrounding symptoms reporting and exposure notification apps. Dr. Gee will tell you more about it. It was extremely complex. What did we have? Well, we had expertise in molecular biology and immunology. We had a lot of volunteers. That's another lesson learned. Volunteerism does help. from multiple schools and departments, a donation from Hyundai, the car company, which came to us thanks to Dr. Gee, actually, and some space in the LSU Healthcare Network clinic. So a lot of meetings ensued among experts in infectious diseases, public health, laboratory science, and epidemiology. What would have been the ideal containment plan if we as a country had been in a position to be proactively responsive to this? Mandatory masks and social distancing right away, work from home whenever possible, lockdown only if needed. We actually never closed the campus completely, unlike a number of other universities around the country. Universal use of a symptom reporting app, such as COVID Check, and exposure notification using either Bluetooth or GPS. Repeated testing, and I emphasize repeated because what we learned very quickly about the incubation period of the virus told us that a single time point testing was not sufficient of everyone coming to campus with a highly sensitive and specific molecular test. I'm going to remind everybody that at the time, there was no FDA approved or FDA authorized. There's a difference between these two tests. And so we had to wait for one. Rapid turnaround time of test results, because with an incubation time that is between 5 and 19 days, you have to know as early as you can that you've been exposed, quarantine and contact tracing of positive cases. Well, we couldn't do a lot of these things. So what we ended up doing, the actual containment plan, of course, mandatory masks and social distancing, work from home whenever possible, PCR testing and isolation, not for everyone because we didn't have enough testing or personnel, but only for symptomatic or high-risk exposed individuals by CDC criteria. Thanks to the Hyundai donation, we acquired 10,000 testing kits of the C-Gene Allplex, and we're waiting for its FDA authorization. As soon as it became authorized, we deployed it. We started with exposure surveillance with a rapid antibody test for asymptomatic individuals. And then we reflexed antibody positive subjects to PCR testing to save PCR kits. We picked the rapid test for a very important reason, because we did not want people to wait several days for an answer. We had to build an ad hoc registration portal for testing, as well as a portal for self-reporting. In the ad hoc registration portal, what people did was essentially give a brief history of their symptoms and exposure that allowed us to discriminate between people at high risk and people at low risk. Again, another lesson learned, IT was vital in our effort. We had to build all this from scratch. The results of antibody testing were reported by text message within 15 minutes. The way we set up the testing clinic was such that people could wait for their antibody testing results while being socially distanced and be tested by PCR immediately if they were antibody positives. The results of all testing were made available to a secure portal, and the PCR results were reported as per statute to the Office of Public Health and also to the School of Public Health for the purpose of contact tracing. We eventually set up a central number to call for information. Originally, their number was my desk, and I received a very, very large number of phone calls. Now, luckily, there is a specific clinic that takes care of that, and it's staffed with 2 physicians, a PA, and 2 RN. So what does this look like from the standpoint of a workflow with back to work as the goal? People who register into the portal, symptom screening, Symptomatic people would be directed to isolation, PCR testing, and reporting to OPH, and after quarantine were allowed back to work. Asymptomatic people were brought in for antibody testing and past symptom screening. A lot of people who swore up and down that they did not have any exposure, once you ask them carefully, and this is where our medical students learned a lot about history taking by volunteering in this program, you found out that, oh yeah, no, I never, yeah, my wife was really sick with it. So, so you really do have to know how to ask questions, and that's still a human skill that a computer could not have duplicated. If they were antibody negative, they were allowed back to work with masks and social distancing. If they were antibody positive, were immediately tested by PCR. Pending the results, they were asked to isolate. And of course, the results of the PCR were reported to OPH. Repeat as needed. This was not a once and done. People kept coming in for testing. And it starts back here. Now, all the data from this were collected as a de-identified database from these sources, from the antibody lab, from the PCR lab, and from the registration website. And there is an IRB approved protocol to analyze the results for epidemiology purposes. So what did we learn? As I said, we're still analyzing a lot of data, but between June and December, we tested approximately 1,600 individuals, a little more, many of them repeatedly. Exposure rates were high. At least 1 in 5 of us was exposed at some point to SARS-CoV-2, 21%. Interestingly, 30% of people who were antibody positive were also virus positive, whereas the population level positivity rate hovered around 6%. What does that mean? It means two things. Not everybody has immediately neutralizing antibodies, and people who thought, oh, I have antibodies, I cannot transmit this virus, were wrong. We had to vigorously prevent some of these folks from taking care of patients who thought that their antibodies were a sort of get out of jail free card until they had their virus test. But what they also told us that gating asymptomatic individuals by antibody testing enriched our PCR positivity rates by 5 times. IgGs and IgM appeared at the same time, unlike what everybody learns from immunology textbooks. The reason for that is very interesting, but I'm going to wait until the Q&A if anybody wants to know it, because I don't want to be too long. We did observe many clusters of asymptomatic cases. So if we found an asymptomatic person in an office, a few days later, a half a dozen other people from this same office were infected. None of these people had symptoms. This is how this virus spread. Virus load, as estimated by cycle threshold values by PCR, tended to be low for asymptomatic cases. What does that teach us? That asymptomatic transmission was common, but non-pharmacological interventions like masks limited virus loads. So they acted, if you will, as a sort of pre-vaccine. Also, we learned that antibody responses did fade. So don't hold your breath that you're going to be protected for life after one infection. That is most likely not the case. And that reinfection, we observed reinfection before it was published. In some cases, the reinfections were asymptomatic, and in some cases, they were symptomatic. So yes, you can catch it more than once. And this is because there are plenty of genetic and non-genetic differences between individuals in their ability to mount a protective immune response. So how the program matured, we kept the PCR test for clinical purposes because it has a rapid turnaround time. And we're now actually using the electronic health record for registration and reporting. We centralized a dedicated campus clinic so that anybody with a question only gets an answer that's consistent. And we have set up sequencing. The Illumina COVID-seq sequencing test that can sequence up to 384 samples at a time. So now we can do variant calling with fast turnaround time. Vaccination is ongoing at a brisk pace. After that, those who elect not to be vaccinated will be screened by continual testing using the PCR assay and the COVID-seq for variant identification. We're validating saliva and nasal sampling to facilitate screening of unvaccinated people. And we've discontinued routine antibody testing because by now, a large number of us is going to be positive. And speaking of variants, I'm going to remind you that adaptability is a selectable character. So this is the genome of SARS-CoV-2. These are called open reading frames. For those who are not molecular biologists, these are genes. Each one of these segments is a gene. The little spikes here are mutations. You see how many mutations? And this is the spike. This blue here is the bit of the viral genome from which the vaccines are made. Look at how many mutations. These are only mutations that change amino acids have been recorded so far. So this thing is mutating. Faster. This is a calendar with the number of new lineages that appear. The slope of this line, for those of you who remember your statistics, is rising. Last month, I would have told you that the capacity of the virus to generate new lineages was 22 per year. Well, now it's almost 24. So you can see these outliers, these points here that separate more widely from the main family tree of the virus. These are viruses that contain more mutations. So it's mutating faster. Why? Because we got more selective pressure from medications and vaccines. And this is another view of it. This is the hit parade of the most successful lineages. Until recently, see, this is what started. A was the first lineage that appeared in Wuhan. B was its firstborn, if you will, and B1 was its secondborn. Now look, A and B are almost gone, but B1.2, which is a grandchild, was very successful until recently, and now we got B117, who's a real record breaker. This is the British variant. This green one here is the Brazilian variant, and this aqua is the South African one. They're expanding. This is how many variants were circulating just among LSU people between June and December, 28. So this virus has a lot of branches in its family tree, and it's very ready and willing to evolve. So what are we going to need? We're going to need collaboration between institutions in Louisiana and beyond to keep track of viral evolution, identify quickly the variants of concern, for example, in the receptor binding domain of the spike, which is what the vaccines are made from, or in the RDRP gene, which is what remdesivir, the antiviral medication, attacks. These variants could cause resistance. IT, again, informatics and bioinformatics is going to have a huge role, because once you have a sequence of a variant, you can figure out whether it's more or less immunogenic, whether it's lost epitopes, whether you need to adapt the vaccine. And as you might have seen from the news, there already is a variant vaccine in clinical trials. My prediction is get ready for boosters, roll up those sleeves, because we're going to need a second generation of vaccines at some point in the future. And I'm going to stop here and thank a lot of people. All this was a large team effort, and I put here Dr. Gee's name in gold because she and I have had more meetings and phone calls about this than either of us cares to remember. But she got us that original Hyundai grant that paid to get the testing started. But the number of people that deserve mention is too large for me to read them all. But it was a major effort. Thank you, everyone, and I'll be happy to take any questions.
Thanks, Lucio. So if you stop share, just for the recording purposes, perfect. So Dr. Gee, it's all yours.
Great. Thank you to President Guice for joining us, and for all the participants today, and to Lucio. He's one of my new BFFs who I met when I came here to the Health Sciences Center after being health secretary, and just such an admirable, phenomenal person, but also a great teacher. And he's taught me, I am a physician, a practicing OB, but medical school is long passed me by. And so he's reminded me of all of my genomics and taught me and helped me navigate this pandemic. So thank you to Lucio. And I would thank the same set of folks. You know, this has been a team effort in all of the aspects that team means. And I like that Lucio showed Darwin and talked about evolution. And one of the things that is certainly the silver lining of COVID, and I'm going to talk about negatives and silver linings. I'm also going to walk you through the timeline from a physician's eyes. I know at LaTeX you have some science, but you don't have medical programs. So you may not have experienced what we experienced here. And certainly being in New Orleans was very particular, and I'll tell you why in terms of our experience with COVID. But you know, one of the things I like to say is when confronted with a changing world, if we choose not to respond, not to adapt, that the decisions affecting our future are taken away from us and made by others. So this was really a determinative virus. It was one where societies throughout the world had to decide how they were going to address it. And the way that Lucio explained some of our decisions was a microcosm of what the whole world had to decide, right? How are we going to test? How we can't fight an invisible enemy. And at the very beginning of this epidemic, we had no idea. You know, we kind of knew what the enemy looked like, but we didn't know where it was. Very, very challenging. And so, you know, I live as does Lucio, in New Orleans. So here in February of last year, we had Mardi Gras. Right? Mardi Gras is a time when 1.4 million people from all over the world come to our city to celebrate life. It's a joyful time, but unfortunately, we caught not only beads, but COVID, right? And weeks after Mardi Gras, and almost to the day, in terms of the way that COVID spread, New Orleans became the hotspot in the globe. We had a higher transmission rate here than Northern Italy. And I don't know if you remember the pictures of morgues and body bags in Northern Italy, but it was pretty dire here, and we were ventilators away from running out. Now, this was a situation that happened in very few communities throughout the US, and you've probably heard about what happened in New York City. What we experienced here was very similar. And in March of last year, doctors who worked here at LSU and throughout the city for various organizations were having to sometimes go without the proper protection, nurses, you know, respiratory therapists, or take their masks and put them in paper bags and reuse them. People had to live with the fear that their job would lead to death. You know, it was kind of, I don't know if anyone's read Camus' The Plague. It's one of my favorite books, but in this it talks about a heroic doctor who goes in the midst of a plague and saves lives and ultimately dies. This was the dire situation we had, and I want to recognize before I continue that we've lost so many, you know, millions of people in this world. Some of you may have lost somebody. You know, here in New Orleans, we've lost thousands of people, and too soon. And it was just a tremendous difficulty. I had the opportunity, well, I had the sad opportunity to see September 11th out my window. I was a medical student in New York, and I watched the second plane hit the tower. And I speak Spanish, I worked with people on the West Side Highway and counseled them about how they felt. But that was one event, right? That was one single day. It was the most traumatic thing I'd ever seen. But this was day after day after day of trauma. You know, not only watching people die, but watching them die alone. You know, I had a lot of people who were fellows and doctors, and this experience was unprecedented, you know, having to hold someone's hand in an ICU with an iPhone. I mean, that's never happened in our lifetime. So it was just, I want to just highlight what a tremendous personal toll this took on healthcare workers, on the docs here at LSU, our students, people afraid that doing their job, their daily job, would cost them their life. And in some cases it did. You know, we quickly course corrected. I have to commend our governor and our mayor here in New Orleans. Our governor is someone I had the great pleasure of working with side by side for 4 years. And I can tell you, he's one of the most admirable, ethical people I've ever come in contact with. He knows what he doesn't know, which is a wonderful quality, rare quality in leaders who are often narcissistic. He asks good questions. He listens to the answers. And he listened to his staff. Alex Bu, who I had appointed to lead public health, quickly and ably took the lead. He listened to Alex. We shut things down. I think in so many ways necessary because of the situation I described here in Louisiana. It was so bad. And you know, so many people from all over the state come to South Louisiana at this time, and the virus was spreading like wildfire. So what we quickly started dealing with was a few things. One, as I mentioned, PPE, or a personal protective equipment. So we didn't have enough of it. And I ended up through David Begnaud, who is a CBS news anchor and a local boy. He grew up in Lafayette. I ended up getting on TV and, because, you know, sharing nationally how dire this was. And finally, through several of us raising the flag, we got attention, but it was throughout Louisiana. We didn't have enough PPE. And I remember calling, my dad happens to be president of West Virginia University. I called up the health sciences chancellor there and said, we need it. Do you need it? Can you send it to us? And he said, well, no, we really don't have COVID here, but we've got to save it in case we do. And I said, well, people are dying here now. Send it now and we'll replenish you later. But there was that fear throughout the country that we didn't know when it was coming. Again, back to this theme of invisible enemy. Nobody knew where or when or how much. So we really had challenges. And so I spent a good part of March in what I felt like was eBay China. I mean, it was calling people, you know, my friends of my friend who lives in San Francisco's daughter-in-law's daughter, you know, oh, you used to sell, you know, bottles from a Chinese factory. Now we're making masks, and trying to figure out if it was legitimate or not. And then we just order 100,000 hoping for the best. I mean, this was the kind of in this country, this United States, this most developed country of the world, we were dealing with this ridiculous disorganization, right? Trying to figure it out. Often we would find ourselves bidding against each other, another hospital in the city, or FEMA would then swipe it and say, oh, sorry, FEMA took your, and the same kind of thing happened with ventilators. And it became political. Unfortunately, this virus should have never been a political thing. This is a RNA encapsulated by a protein. It is programmed to kill. It is unfortunately due to something that happened in nature. It is not a political virus. It became one. And all of those decisions and about masking and all of that started again, probably about those times when they shouldn't have. I think we could have gotten a lot better control of this if everyone had just that we knew. Well, the other thing to say is early on, we just didn't know. We were doing what I call hygiene theater all over the place. You know, everyone's buying. And I remember I did this. I went to Home Depot trying to find Lysol. There was no Lysol. We're all buying it. Of course, we all remember the toilet paper wasn't there. You know, but we were thought, well, we just disinfect everything and we won't get it. Now, it turns out that only 1 in 10,000 people get this through a surface. So that was even a non-issue, but we didn't know. We didn't even know how you get COVID. Right now, we know you get it through breathing. Now we know that's why masks work so well. So just to set the stage, that's those discussions going on. Ventilators were hard. There were ventilators, but The ventilators were, it was unclear why or how or when they would get here. I remember the governor said on one press conference he needed 2,500, but he got 200. So it was scary times. So, at the same time, we started to, as the rate started to lessen, as we had the lockdowns and the results of those lockdowns, and I doubt, in Ruston, that you've experienced what we did here. I mean, again, it was very scary, the hospitals filling up, everyone knew someone who knew someone who had died. I mean, just incredible stress. But things started to get better, and as the clouds lifted, and we were able here at LSU to start focusing on things other than making sure that our doctors, and nurses and folks who needed to take care of patients were protected on a daily basis. And we started to think about how can we make the invisible visible. And I got a call from Cedric Richmond, U.S. Representative Richmond, who's now at the White House, and he said, look, we got a testing machine. Do you want it? And I said, well, hell yeah, we want it. I don't know what to do with it, but I bet I know someone who would, and that was Lucio. So Lucio is really to credit for all of that. I just got the machine and the testing kits. He was the one that made this program happen. And you heard from him about all the genetic variants, what he's seen, how many people were tested. But it was a very powerful tool to start to make the invisible visible. We also started to debate, how do we know if someone's been in contact with someone else? How are we going to figure this out? LSU doesn't have enough staff to call everyone and to make sure that everyone is notified. So we started to think about technologies, and we looked and evaluated a variety of technologies. Ultimately, really not, I would say that was one of the things that wasn't particularly successful, didn't really arrive at anything that worked very well. In the meantime, the state went forward, but it took them a good 6 to 7 months to work with Google on a single contact tracing technology that uses Bluetooth instead of GPS to figure out where someone's been and if they've been close to COVID. We've been working on making sure that we can get people the vaccine. And so one of the remarkable things that has happened, and it really is, I think, the most remarkable discovery in my lifetime, is that we have developed a vaccine. Now, if you can recall, back in February, when people were starting to talk about the vaccine, the discussion was, wow, normally it takes, minimum 2 years, if not 10 years to develop a vaccine. I mean, we think about polio, Johannes Salk. I mean, how long did it take to solve these problems? If you read, which I would suggest you do, there's a book called The Great Influenza about the Spanish flu, the last epidemic of this proportion in the world. They never did find a vaccine. In fact, for most of the epidemic, they didn't even know it was the flu that caused all of this death. So we were so far ahead. And what turned out to happen within less than 9 months, which is pretty miraculous, is that we have a new type of vaccine. It's something that's never been done before. This is a vaccine that, instead of taking an inactivated virus or a virus that's not infectious and putting it in your body, it actually teaches your body, gives your body a blueprint to make ammunition against the virus, or what's called mRNA. So it gets into your cells, and your cells then become a factory to produce ammunition against the virus. So it's pretty elegant and in so many ways lower risk, because you're not actually creating a virus in your body. You're just creating things that identify the virus and are able to attack and kill it. It's like creating really high fidelity ballistic missiles that can target and kill the intended target. It's pretty neat. So that I really hope that these vaccines will lead to so many new things, maybe cures for cancer, a vaccine against AIDS, or even the common cold. So I think this is a renaissance has begun in terms of genomic medicine. So that was exciting. So we were able to get the vaccine by December. The United States had the vaccine, and by January, Auctioner was blowing and going, giving the vaccine out. We were able to get almost 1,000 of our faculty vaccinated, and then LSU obtained a lot of vaccine, and we were able to vaccinate the rest of our campus who wanted to be vaccinated. So it's been an incredible journey. There's certainly a lot that's unsure yet. We now have, most of our people are back on campus working. I've been here every day because I'm a mother of 5 kids. There was no way I was getting work done in my house. So I've loved to have had this office, and my youngest are 8-year-old twins. So the bright spots, let's talk about those, and then the challenges, or as we talk about at the dinner table, are roses and thorns. So what are the roses? The roses are this vaccine. It's extraordinary human accomplishment, achievement that will save so many lives and could be utilized for other diseases and conditions. The volunteerism, the outpouring of love and community and concern. You know, I created with partners from all over the state. You might have had La Tech students. With folks from Louisiana, ULL, and other campuses, a volunteer website. And within a week of creating that website, we had over 2,000 volunteers, doctors, nurses, undergraduate students, everyone wanted to help. Another bright spot, you know, I'm a professor of public health. Most people don't give a hoot about public health or even know what that means. But I bet you if you talk to Americans today, I bet you almost all of them would know what flatten the curve means, right? That's epidemiology. That's public health. Flattening the curve is a public health concept. And I really don't think that we're ever going to have to make this argument that public health matters again. You know, there is now an understanding that public health is a business imperative, that to operate as a well-functioning, you know, financially successful society, we have to have healthy people who aren't giving each other disease, right? And that means that we're going to have to think about public health in new ways. And as a professor of public health, that excites me. And then finally, disparities. Look, I have done much of my career. My two passions are health disparities and women and children's health. Health disparities was kind of a difficult thing for people to get their heads around. I was able, when I was health secretary, to found the South's first Office of Health Equity. And we talked a lot about health equity, but people didn't really understand what that meant. But we could see it in COVID. We could see it with the numbers of dead. So many more Black folks than white folks died. And so it became something that people also just understood, that health and were there. And I was able to co-chair for Governor Edwards his Health Disparities Task Force. And I think there'll be a lot of positive movement to deal with health disparities. What are the challenges? Well, I think mostly what I worry about now is we have a mental health crisis in our country. We have 40% of Americans are depressed. 13% of them, when surveyed last month, said they have thought about suicide. 13% have thought about suicide. And if you ask people in their 20s, probably many of you are, double that, double depressed, double suicide. So the majority of young people are depressed. I think someone asked me why, and I don't know. I have teenagers and I have 8-year-olds. I think my 8-year-olds are okay. I think my teenagers are pretty depressed. Why? Because my teenagers have expectations about what should be happening in their life now. My 8-year-olds are doing just about what they would do. They're coming home, they're going to school, whatever. But teenagers want to socialize. This is one of the most important times for development, and they can't. They're isolated and alone. So I think we've got to figure out how to get out of this now that we have the vaccine. We've got to figure out how to go back to school, go back to work, socialize, reintroduce, and deal with the depression, isolation, and loneliness that's so pervasive. I'm really proud to be at LSU, to have been at the state university that is the only institution in the state that has dentistry, nursing, public health, medicine all on one campus. And also to have phenomenal professionals like Lucio, who are world experts in genomics and helped us to come to an understanding and to help our community come to an understanding about what this virus is. I think we have had a phenomenal opportunity to lead, and I think we have done that. But I think, you know, we have some long days ahead. I don't know that our world will ever be the same, but hopefully we'll take the good, we'll take the roses and dispense with the thorns. So I'll just stop there, and I think Lucio will be open to taking questions.
Yeah, thank you so much. So yeah, we will take questions, and Dr. Guice, I will defer to you in case you have any to start us out while people type them in. If not, Mary and I always have questions, so jump right in.
Yeah, first let me say thanks, Dr. Gee and Dr. Miele, for coming in and sharing this incredible information with us. I know it's very informative. I got a million questions of my own, but you know, to me, it's just the incredible pace. If you think back, you know, 12 months ago and where we were and where we are now, and that's so extraordinary. There had to be a lot of openness of sharing information. We tend to be very protective of information, but I'm just kind of curious what you thought, again, were the major factors that led to the accelerated pace.
So sharing information is crucial, and I'll take a stab at this, and Dr. Gee can correct me. Without collaboration, this would not have been possible. That big graph that I showed everyone with how the virus evolves comes from a public website, which everybody can access on their computers, that was actually created to collect data on influenza pandemics. The website is hosted in Germany. It's called Guice, and it's free. So you upload your sequence data on it, and it's got all kinds of analytical tools. Everybody in the world who sequences a COVID virus uploads their data to this free open website where everyone else can see exactly what this virus has that's different, and plan accordingly. That is actually what I was saying earlier, the importance of informatics. Part of the reason why we can do these things is that we live in the fast internet age. It would have been impossible to do so otherwise. I mean, from the standpoint of the lab that we set up, the instrument came from California, the kits from South Korea, and the RNA extractor from Germany, because that's where we could find them. So there was actual international cooperation, not only in sharing of information, but sharing stuff that was available when none was available in a specific location.
Yeah, go ahead. Yeah.
Yeah, well, I mean, this was World War C, right? So this was, it's a lot easier. You have a lot more desire to have the fire department come if your house is burning down than if you just have a grill fire, right? So I think, this was something where there was a sense of urgency. There was a tremendous investment, Project Warp Speed. I would commend the Trump administration for the Project Warp Speed and for prioritizing this important issue, and also for taking some of the risk off of the pharmaceutical manufacturer, saying, look, we'll take, if you don't succeed, we'll pay for it, which was really important. Normally that kind of risk aversion is what takes companies so long to get to an end. So I think, that's it. I think we would have finished a lot earlier, again, back to the politics. And I think Caroline Brakefield brings up a good point. Look, there are some things like I think we've made a lot of mistakes. And if you survey Republicans and Democrats, you find interesting things. Republicans tend to be more against mask wearing, which shouldn't happen because masks work, and would have been, if we had all just agreed to wear masks, it would have been a lot quicker way to open up and to get to the opening up. But Democrats, if you survey them, are much more likely to think that they almost quadruple the percentages of people they think are going to die from COVID or be in an ICU. So when you go to states, and I happen to be in Massachusetts giving a speech in honor of my late husband a couple months back, and it was like a ghost town. I mean, none of these kids in school, all my friends depressed who are parents, nobody helping them, an overreaction, arguably. My kids have been in school since August, and not a single kid at that school, not one K through 12 kid got COVID at school. So I think we made a lot of mistakes that were panic, that were caused by our panic and not caused by data orientation. So I hope we learn from this pandemic that in the future we need to stop whatever emotions we have, look where the data takes us, and let's just go there instead of trying to bring all this into it. And then also, I believe personally, we did it in New Orleans, and I think we should have, as a nation, we should have put schools first. Schools before bars, schools there are kids who have lost a year of their education, kids who are disadvantaged. Child abuse went up. When I talked to the head of Children's Hospital, it's not always good for every child to be at home, right? There are children who have suffered who will never recover from what's happened to them. So I think we have to balance all these things. And unfortunately, in this hyper political world, people get into camps and it's hard to talk across those camps.
Thank you.
All right, I've got another one for you guys. Okay, so we keep hearing that we may have to get boosters for the vaccines from time and time again. Is this because you think the virus is continuing to evolve, or is it more because our vaccines aren't as effective as we had hoped they would be?
Okay, I can take that one. May I share my screen again? This is easier done if I can pull up the slide with this slide. It's not in presentation mode, but it'll be. Can you see this?
Yep, looks good.
So this blue box here, this is the whole RNA of the virus. This blue box is the bit that the vaccines consist of. The vaccines are this little piece of RNA taken out of, copied from the viral genome, and as such, as RNA injected into the body so that it makes this protein here. Now, yes, as you can see from the little spikes here, it is mutating. And that's not surprising because of the nature of the virus. It's a single-stranded RNA virus. Whenever it copies itself, it makes mistakes, and these are mutations. Then natural selection intervenes. The mutations that help the virus are more successful, and so those mutations help the virus have more babies, if you will, and the mutations that don't help the virus die off. That is one reason why very likely we're going to need boosters. Think of the flu. I take a flu vaccine every year, and that's because the influenza virus is really good at mutating. It also swaps pieces of its genome with other influenza viruses in chickens and pigs. And so what's good this year, it's most definitely not going to be good next year. I don't know if 1 year is the exact time, but something very much like that is happening with this virus. Now, as to the other possible reason for the booster, it's not so much a matter of the vaccines being effective or not effective. It's a matter of how our immune systems respond to this particular virus. One of the closest cousins of this virus is OC43. OC43 doesn't tell you anything, but if I say the common cold, that'll tell you something. So the viruses that cause the common cold include coronaviruses. OC43 is similar to SARS-CoV-2, although it's a lot less pathogenic. Do you have permanent immunity when you catch the common cold? No. Well, the natural immunity to this virus, to this coronavirus, doesn't last more than a few months. That's been determined. And that's because these viruses have engineered themselves to not stimulate too strong an immune response. Also, you got to be careful with vaccines that you don't drive the immune system into such a frenzy that it becomes dangerous. The immune system is like calling in an airstrike. You don't want the airstrike to bomb everything. So you have to be very careful how you design a vaccine so that you get immunity, but you don't get autoimmunity, which is dangerous. So there's only so much you can do. There are only few viruses that cause lifelong immunity. If you're in my age group, you may need a booster of your shingles vaccine, even if you have chickenpox vaccine. Tetanus shots need boosters. Smallpox is one of polio. Now, the reason why polio doesn't need a booster is actually very interesting. The polio vaccine is a live virus, which competes with the garden variety polio virus in the environment. That's why you don't need a booster for that. But for most vaccines, immunity doesn't last forever. So that's why I think that boosters are inevitable.
Lucio, is that also some of the argument for people who have had COVID to get the vaccine? Is it promoting an elevated immune response? How do you talk to people who have had COVID who say they don't need the vaccine? I think that's a problem we see in a lot of students is they had it, so why take a vaccine that they may see as risky?
Because, so there's two answers to that. First of all, again, folks who think like that think of COVID as measles. You've had it and you're done. You need to think as a really, 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 really nasty common cold. You've had it and you can get it again. I have seen reinfections even in our own limited few thousand case experience. I've seen people who were sick get sick again. And of course, the virus is changing too. So that's one. The other answer is, in medicine, you always think in terms of risks and benefits. So you're not weighing the risk of taking the vaccine against the risk of not taking the vaccine. You weigh the risk of taking the vaccine against the risk of catching the virus, which is going to get you if you don't take the vaccine at some point. We've heard a lot about these rare sinus thrombosis that happen in very, very few people that are vaccinated with virus-based, adenovirus-based vaccines. The same risk is 10 times higher of the exact same thrombosis if you catch the real virus. So you cannot escape risk. You have to pick the smallest risk. And the smallest risk is by far the vaccine versus the real deal. With the vaccine, you're only getting this blue box. With the real deal, you're getting it all. But the risks are the same multiplied. So that's usually my answer when I'm confronted with this question.
So, Lucio, there's a sidebar about a student saying that masks are not worn properly, so not effective. That is actually not true. And I mentioned in the sidebar that the same thing could be said of seatbelts. There are always going to be people that don't wear a seatbelt properly, but just because a few people can't put on a seatbelt, I mean, yes, if you put your mask like this, it doesn't work, right? But if you're going to wear it, even with partial covering your mouth, you're lowering risk. And all this peer-reviewed scientific evidence, which I referenced in the right, back to let's let data drive decisions, not emotions or what politicians say. It says they work, right? Several studies have been done in countries. We know in multiple countries that masks work. So this is just, it should be something we do not debate. Given that we know they work, given that we know that it comes from respiratory droplets. I mean, you got something in front of your face, it's going to prevent respiratory droplets. So I don't think we should be debating that anymore. Let's just wear them so we can get this thing over with. And if people are not intelligent enough to know that a mask should cover your nose and mouth, I don't know what, but the same thing could be said of getting in a car with no seatbelt. I mean, yes, we have seatbelt laws. There are people that drive around with no seatbelt. They're more likely to die when they get in a car wreck, just like you want to walk around with no mask and breathe on other people. I like one of the things that President Xavier said. He said we shouldn't have the privilege of breathing on other people and making, and in some chances having them die. That's not a privilege we should have. Anyway, that you can tell I feel strongly about that, but that's basic public health. When we have people dying throughout this country, I don't think we ought to be debating this anymore. And again, it shouldn't have been and could have been avoided as a political issue. Unfortunately, it was, sadly. There was a question about vaccine hesitancy. But look, the other thing is, I think what's going on, and I want to say this, look, if people have questions, and as a doctor and my talking to patients, every perspective is valid. I'm not saying your perspective is not valid. I'm just telling you what the data shows. And we've got to let our public policy decisions be driven by what the data shows. And if the data showed that masks don't work, then we shouldn't wear them. But anyway, that's the side. But on the vaccine hesitancy, it's hard because there are a lot of people. First of all, prior to COVID, there was a very large group of US people that were anti-vax, right? Just would not vaccinate their children, thought that no matter what the evidence told them, that the mercury that had been in vaccines long ago, but has long been not in the liquid that has the vaccine active materials, that this would cause autism. There's no evidence of this, but regardless, there was all of this background. And then there's the background of folks who are, and there is a significant issue of vaccine distrust among Black Americans who feel that were not part of the studies, which is a valid concern because the studies were not representative of the US population. And also that there's a history of well-earned distrust of the medical system. So people feeling like, I don't want to be a guinea pig. I don't want to be the first to do this, and I don't want anything to happen. But first, what I say to my patients, and I think where we are now, is now half of the US adult population has gotten a vaccine. So we have enough millions of people who have had this. Lucio mentioned the very rare blood clotting. I mean, when I prescribe birth control, we have a 1 in 10,000 risk of blood clots. We're talking about a 1 in a million risk of blood clots. So in some ways, I think it was a mistake to pause the J&J. I guess we could debate that, but because there will certainly be people who die of COVID in the interim because they didn't get a vaccine because they didn't have access. So, but look, I mean, everything has risk, as Lucio said. When I walk across the street, there's a risk to me. When I get in my car, every time I get in my car, as I so well know because I nearly died in an accident, there's a risk. But the risk of vaccines is incredibly low. What we know is this is a nasty virus. This virus doesn't kill everyone, but it kills a substantial number of people, enough that we've had, hundreds of thousands of Americans die. Right. So I think that, but not a single person to our knowledge has died of the vaccine. So to me, that's very compelling.
So Rebekah, since you are an OB and we're talking about vaccine and hesitancy, I've heard a lot of people concerned about fertility once they get the vaccine. Can you speak to anything on that?
So I've been talking, I've spoke this morning with the president of ACOG, which is my association, the American College of Obstetricians and Gynecologists. And I don't know where the fear is coming from. I think I described earlier that the mechanism of this vaccine is to teach your body how to make the blueprints for the missiles against COVID or the antibodies against COVID. And it's not, doesn't have anything to do with placenta. It's very targeted to this virus. And so there's no, and again, so many people vaccinated and also pregnant women are much more likely to die of COVID and have complications of COVID for reasons we still don't understand. So, my professional opinion, my association has come out, I and the association both believe women should have the vaccine. There is no mechanism that I think could explain any worry about infertility. I mean, then, you have a certain number of eggs you're born with when you're born. You have those throughout your life, and over time, those eggs die off, unfortunately for us. But there's no evidence that the COVID vaccine attacks your eggs or does anything to your endometrial lining. I mean, so I would say to people who are concerned, let's think rationally about this. What am I worried about happening? And is there any evidence that in any one of these tens of millions of people worldwide that have been vaccinated, that this has happened to any of them? And if the answer is no, you're more likely to die of COVID or get COVID than to have the vaccine, than to have a problem from the vaccine. And there is no evidence that infertility is a problem because of the vaccine. So I think it's important that's how I like to think about it. There are, on the other hand, we haven't talked about children. I want to know, I have 8-year-olds. I want to know, my 17-year-olds have been vaccinated because they've been studied. I have not, and nor would I be able to get from my 8-year-olds a vaccine, but I think it is important to have data to drive your decisions. Children's immune systems work a little bit better than adults' immune systems. So I think there are some valid concerns in young children, which hopefully will be addressed in studies. But in terms of pregnancy or wanting to be pregnant or being of reproductive age, there just isn't a mechanism or any evidence that this happens. And I think it's very unfortunate that this fear has been so pervasive, because as a result, this is one of the biggest populations in this country that is not vaccinated. And that concerns me.
Dr. Mealy, can I ask a question? As new variants of the virus become apparent, serious variants that may require a different vaccine, can you talk a little bit about the timeline for development, what we can use from what we've already had, and maybe even extend that to new non-COVID viruses?
So that is actually, if we can even speak about silver linings, as Dr. Gee was saying, that is one of the silver linings of this pandemic. Now, first of all, the mRNA vaccines, which come from the world of cancer, the reason why we got to them so quickly is because there already were 135 clinical trials of mRNA vaccines in cancer immunology. So this is a triumph of basic science, because when HIV was discovered, when I was a fellow, we had no idea how to make an mRNA vaccine. We could barely read the mRNA of the virus itself. They can be adapted very quickly. So in a timeline in the order of 4 to 6 weeks. So Moderna has already initiated a clinical trial funded by the NIH of a vaccine that includes the B1.351, which is the South African variant. So we're going to be able to adapt these vaccines quickly. In terms of whether this can be applied to other things, yeah, I would imagine so. I mean, this is possibly the cleanest way to make a vaccine, because a vaccine consists in having an extraneous protein or polysaccharide in your body that you make antibodies and T cells against. Old generation vaccines are made up of either dead microorganisms, inactivated microorganisms, and more recently, purified proteins. This skips all those steps. You don't have to make these proteins in big bioreactors, so it's actually even cheaper. You just make the RNA. Your body is the factory that makes the antigen. So that is a tremendous technological advance, which will lead us to produce vaccines that were thought to be impossible until recently.
So there was a really good question about why do people have flu? If all the COVID vaccine does is cause you to make spike proteins and get your immune system going, why does it cause flu-like symptoms? I can't say this exactly for the COVID vaccine, but in general, vaccines and our response to illness, whether it's fever or other types of, nasal congestion, things, that's caused by your immune system, not by the actual virus. So your body has a fever because you're over millennia, your body has learned that if it becomes hotter, then it's harder. It's not as good of an environment for viruses. Your body creates mucus and stuff like that because it traps viral particles and makes it. So these are things that are more related to your immune system than the virus itself, if that makes sense.
That's exactly right. I mean, when your body encounters a virus, it activates your immune cells. The immune cells produce chemicals called cytokines. They give you fever and they make you feel tired because your body needs to rest. And as Dr. Gee said, if you're hotter, the virus has a harder time reproducing. Now, unfortunately, this virus is already well adapted to fever because it comes from bats. Bats have a body temperature of 42 degrees Celsius. Don't ask me what it is in Fahrenheit. After almost 40 years in this country, I still use the metric system. They're much hotter than we are. And so when we develop a very high fever from COVID, the virus goes, oh, cool, I'm home now. And it keeps going. So, but that is the response of our bodies to the infection that causes it.
But it's a good question. I don't know if Lucio and I are actually answering it perfectly, because if you don't have the virus, you don't have cytokines. So why?
Oh, because just making an antigen that activates enough of your T cells
To do cytokines?
or produce cytokines, you don't need to have a live virus.
All right, Lucio, see that?
Yeah.
Yeah, no, but that makes sense. So, but I mean, and what they say is that I actually worried, I got the vaccine and I felt great. And I really worried that I had gotten the
Yeah.
saline, or that they'd forgotten to stick it in my arm. And so actually Lucio tested me for antibodies and I had them, but I felt so well, I wasn't sure I'd actually gotten it. So it depends, because I worried that I kind of wanted to feel sick because I wanted to know my immune system was working.
There's huge individual variability. I mean, in my own family, I've had people who just like you, they had absolutely nothing. I had a little bit of tiredness, but nothing particular. And my cousin was in bed for 2 days. So there's one thing that we should remember. The most variable genes in the entire human genome are the ones that control our immune system. The immune system of every individual is different from another. That's because this is a critical skill of our bodies to defend us from invaders and microorganisms. So our immune systems are very, very, very diverse. Unless you have an identical twin, nobody has exactly your immune system. So each person responds a little differently.
Dr. Gee, you talked earlier about that important topic of mental health, and I know there's another question there, and I'm looking to get as many people back on my campus this fall as possible. I personally think that's part of the solution to mental health, but you said 40% of the population is depressed, and others that have considered more serious things to their bodies. What advice would you have to me as a president in terms of getting us best prepared to deal with the mental health issue?
Yeah, well, first of all, I support getting folks back on campus. We have a vaccine. Let's get people back on campus. Wear a mask. You're required. My 8-year-olds can do it. Our students and faculty can do it. And if they're not doing it properly, we ought to have peer pressure getting them. Or if you keep coming to campus and can't demonstrate you can wear it, you ought to go work from home or go back to home. I mean, I think that's what we do. If you don't have that level of concern for others, and the question earlier was, if you've been vaccinated, should you still wear it? Yes, I do. I do it for a number of reasons. A, to model good behavior to others and to my children who have to still wear them. B, there's still a small chance I could get COVID and then give it to someone else. So I want to reduce, because I'm a healthy person, I want to reduce that chance. And C, I think it's cool. And then, so what would I do? Look, I think it doesn't hurt if you can get access to testing. It's particularly because one of the things that's nice about your geography is you don't have, it's not as bad as New Orleans, where you have people coming in and out all the time. Lots and lots of tourism industry, lots of opportunities for new people to come in. I would probably recommend you have everyone get a test before they come to campus, just demonstrating, because so many people don't have symptoms. So that's a smart thing to do. And you've got great universities to partner with in North Louisiana, Shreveport. I'm sure there's testing capability in all kinds of places. So I would recommend that. You can do in kind of a take-home way or on your campus, or we could talk to Lucio, who's now the expert. He might be able to help. And then I just think, I don't think you should require the vaccine. That's my personal opinion. I told you earlier that I believe in it and I think it's low risk, but there are populations of people who have fear. It's a new vaccine. And I just think it ought to be voluntary. But if you don't take the vaccine, I think you ought to definitely wear your mask and potentially get tested regularly, so that you are aware of your status. So that's what I would do, and I would try to have as much fun as possible. Do your events outside. again, someone asked also the states that are opening up, some of them aren't spiking. I think part of it is because people are still wearing masks in those states, and some of the things people are doing because the weather's better are outside. So keep things outside, and then go from there. But we've got to live our lives. We've already lost, so much. So I think we've got it. Now that we have the vaccine, let's be rational, but get back to it when we can.
So we have just 5 minutes left. I don't know, Mary, do you have any last minute questions? I know there was a lot going on in the chat, and Dr. Gee, thank you for writing back to so many people. I'm sure it's appreciated.
Usually my last question is, what have we learned? What do we still need to do? But Dr. Guice did such a great job about our thorn and roses earlier that I don't necessarily know if I have that question today. To our panelists and speakers, thank you again. What are some parting words that you would like to leave our group with today?
Science works. Follow the data.
Yeah, well, I think let's use this as a rose. I mean, I think this horrible virus has taught us that life is precious and that our days are precious. And so let's reach out and give someone a hug. There are so many of us isolated or depressed. Why don't we think about calling someone we haven't called in 6 months and just checking on them? Go see a neighbor, bring some food to someone, reach out. This is a time that we need to reconnect. And so what can each of us do? Now that the physical danger of COVID, we have this mental health crisis. So what can each one of us do to address it for each other? How can we be a helping hand? How can we be a friend? I think that's everyone's job now. There's just too much depression, too much isolation to have. We will never fill the void with the psychiatrists and social workers and mental health professionals. So we're going to have to get to it, each of us individually. And just sending you the best. I know it's been an awful year, a challenging year, and so I just wish everyone well and appreciate you, Jamie, and I'm so excited to have been a part of this today. And I'm happy to, I'll write in the thing. My email is rgee@lsuhsc.edu. So if anyone has a burning question or wants to debate something I said and you didn't get to on this webinar, please do reach out. I'd be happy to connect with you.
Yeah, I thank you both so much, and Dr. Guice also for being part of the conversation. I think you highlighted a lot of really important lessons and being conscious of what we've done. So like Lucio talked about how many countries and how you two collaborated to take care of things there, and the team that we keep doing that this wasn't just because we had to, but that we found it so valuable that we keep doing that when it comes to science, medicine, mental health, all the things, and we don't forget what we just did. So thank you.
Thank you
Jamie,
for having us. This is wonderful.
Jamie, I just want to thank you and Mary for 8 years of biomedical, or for these new frontiers in biomedical research series that have been really impactful across our campus, and so many great people that you brought here. And certainly Lucio and Rebekah represent the very best. So thank you all.
Yeah, thanks for supporting it. Everyone have a good evening, and thank you for joining us.
You too. Thank you.
Bye. Thank you.
Thank you, everyone.